A quick note before we begin. This podcast dives into real, often raw conversations about life's most profound moments, from a labor's beginning to life's end and all the complexity in between. Some stories may be emotionally challenging or deeply moving. Please listen with care and know that you are not alone. Welcome to the Mamatoosa podcast. I'm your host, Atoosa Benji. Welcome to the Mamatoosa podcast.
Mamatoosa, thank you.
You're welcome. My guest today is Dr. Elliot Berlin. And we were just sitting here calculating how long we've known each other. And I think we traced it back to somewhere around 2002, maybe.
Yeah, almost as long as I know all of my kids.
20. Yeah. I think your wife was pregnant with number 2, maybe.
When we met? Yeah. So there's one who snuck out before.
Something, somewhere around there.
Yeah.
If you don't know Dr. Elliot Berlin, other than having just the biggest heart, the most amount of care, being hardworking and a true colleague and a mentor and someone who you just pick up the phone, send a text, and hear responses within seconds or minutes, if that. Always with kindness, always with an open heart, always with a willingness to help, and a genuine care for pregnant people and families and your mentors. Dr. Berlin is a chiropractor. He practices in Los Angeles. He specializes in perinatal care, preconception, during pregnancy. He will even show up to the hospital and work as your doula or do some chiropractic work to help adjust things, to help labor flow a little bit better if there's a little bit of a stall or an obstruction. He also helps people during the postpartum period and even has clients who are not pregnant, believe it or not, who, including myself, who has really seen your talent and your care and your sense of humor and your creativity. And also the thing about Elliot is that he doesn't have 24 hours in a day. He has about 82. So other than by the grace of God being married with a beautiful family and children, he is an author. He has made many documentaries. He runs a full-time practice. He's a husband and a father and a friend and a teacher and a clinician, et cetera, et cetera. But what I did not know about Elliot is what we're going to talk about today, because I refer many clients to Elliot. And you might say, why would a midwife refer her clients to a chiropractor? And as we know, and I'm sure you know and you've felt and you've seen, there is bias towards chiropractors, that chiropractic care is not real, it's not evidence-based, you could get hurt, you could get paralyzed, it's a ploy for money, go to a real doctor, chiropractors are not real doctors, which actually sounds a little bit like the rhetoric about midwives, right?
Interesting, yes.
Midwives are not like real healthcare providers and it's all woo-woo and what are you doing with a midwife when you could be with a doctor? And did you know that you could die? Like there seems to be a little bit of medical system bullying that occurs. What I didn't know, I was in Ohio many years ago and I was driving around. There were so many chiropractors, doctor of chiropractic care, doctor of chiropractic care. So I said to my friend, I was like, how come you guys have so many chiropractors? She said, because in this particular area, chiropractors can act as primary providers. So they can actually prescribe medication. Some of them can catch babies. Some of them can give IVs and take care of things that a family physician would take care of, because legislature in that area allowed for that through the medical board, which all the different parts of the United States always intrigue me, because even midwifery care is like, well, in this state you can do this, but you can't do that. In this state you can catch a baby, but you cannot carry medication. In this stage you can carry medication, but you can't start an IV. So politics and medicine and the bullying of the medical system has really marginalized very helpful and evidence-based people in the world that can help with many different things, including making pregnancy easier, making birth easier, and allowing for physiological birth to occur, which is, I know, what your passion is. So that was a very long intro. Elliot, welcome.
Thank you. First of all, that was not just a long intro. It was such a nice intro. It was so beautiful. I honestly can't wait to get to know me.
You're lovely.
Thank you.
You are lovely.
Thank
you are absolutely lovely, as is your
kind.
wife and family.
Yeah, that's what you said about locale is everything. It's the same for chiropractors and for midwives. In some places, you have a lot more autonomy and you have a lot more scope. And in some places, you're very restricted. In California, I'm surprised they let us crack an egg, really, because for example, you're allowed to, as a chiropractor, part of our scope of practice in California included is ultrasound, both diagnostic and therapeutic ultrasound. But in the law code around that, it says, except for looking at a baby. So, we can do the ultrasound, seemingly on a pregnant woman, but if there is a baby in there, we sort of have to look away.
Just turn the other way. Yeah.
We're not allowed to look at the baby. And that's, very clearly the American Medical Association getting in there and saying that's our turf. Yeah. Don't touch it, Was
there ever a study that claimed that chiropractors paralyze people and cause strokes? And where did that come from? And is it true, number one, for a non-pregnant person? And number two, are there dangers innately to the pregnant baby and pregnant mother and fetus with chiropractic care?
I will absolutely say nothing is 100% safe. Mm-hmm. Nothing.
Yeah.
Especially if we do those forceful adjustments, those quick, rapid adjustments, you can create an injury. It is a possibility. I always tell my patients there's a small chance from a chiropractic adjustment that we could break a bone, dislocate a joint, rupture a disc, blood vessel, or nerve. That's a stroke, right? The blood vessel. It can absolutely happen. And it's not risk-free. The incidence is very low. But just like everything else, when we make our risk-benefit analysis, what is in this for me, and what do I have to overcome to get what's in it for me? Like I go to the store because I need milk and eggs, but I know that getting into my car, I could be T-boned by an 18-wheeler and never even make it there. But I do a risk-benefit analysis. I really want breakfast, so I'm going.
Yeah.
It's important to know what the risks are and what the benefits are for the treatment. And right. I try to be really upfront about that with my clients. Mm-hmm. Now, I tell them, also the incidence is small, but not zero. I say there's some chance we break a bone, dislocate a joint, rupture a disc, blood vessel, and nerve root. But the good news is I've never seen that happen before. And I also, none of my friends who are chiropractors have ever seen that happen before. It's rare, but you can absolutely create an injury with a chiropractic adjustment. You don't need a study. There are cases. I mean, they
are documented. And in the pregnant person, can you make the person's water rupture? Can you cause a placental abruption?
Like that. Haven't seen or read anything like that, but I think for sure any
intervention is an intervention, right? That has a risk.
Like, I'll give you an example with the stroke. There's sometimes where someone's walking around with a ballooning vertebral artery. It's like, it's ballooning and it's going to rupture. And if it could be they go over a speed bump, it could be they swing a golf club, could be they get a chiropractic adjustment, right? So, yes, I guess it was the chiropractic adjustment.
Yeah, something pushed it over the edge.
Straw.
Yeah.
But if somebody's placenta is like hanging on by a thread, any of those things also can cause a trauma, and it could be the chiropractic adjustment as well. Yeah. Those are so rare that I couldn't even put a stat on it for something like that happening. And I tell them nothing is 100% safe even for your baby. But I don't even know what to tell you could go wrong because it's so rare. Okay. But I will say this, though, because of the hormones of pregnancy, right, the joints are less stable than they normally are. So just a plain old orthopedic injury, overstraining something, is you're greater risk for it during pregnancy than not during pregnancy. And of course, we make accommodations for all of that. But at the end of the day, these are all such personal choices. Decisions. I could say there's a 0.001% chance of this happening, and some people will be like, oh, well, it's like nothing, I'm definitely going to do it.
Right.
And other people, I don't even want to take risk for this benefit. And it's your choice.
You. Absolutely. That's the beauty of it.
If I tell you these risks and side effects, like, no thanks, I'm going home. I'm like, okay, not offended at all.
Right. And a good practitioner will give you options and answer your questions.
Especially here in Los Angeles, there is a good amount of the medical community that's open-minded and really likes to work together in collaboration. Yeah. And I find that our patients get the best results when we're all open-minded and not so, edgy about our turf and, there's teamwork. So there's overlap. There's areas of gray and there's areas of overlap. And I found the same thing with chiropractors and physical therapists,
Yeah.
Sometimes they're very anti each other and it's like, we have too much in common. We can't, we have to keep separate. But I actually find when we're working in collaboration that I can do a lot of things in my area that's unique to me, which is releasing things that are too stiff, too tight, too rigid. And a physical therapist might do things that strengthen things and stabilize things. And so I'm sort of like the WD-40 and they're sort of like the duct tape. And together we make a really good Jewish toolkit of musculoskeletal health and wellness, even though there's overlap areas where we do the same. It's
Absolutely.
We find our strengths and we offer great care together.
And don't you find that when physical therapists collaborate with you and have conversations about a client, both working towards the same goal, that client has better outcomes?
100%. Yeah.
It's
same with the medical doctors, everybody
same
on
with
the team.
It's a team approach that if we move away, if we really come from an abundance mindset instead of this fear mindset of, one, there's not going to be enough in it for me.
Right.
And what are you taking from me? To you're dangerous, in parentheses, I don't really know even what you do.
Right.
But you're dangerous.
That's one of my favorite things.
Right. And then you explain to them what you do and what your scope is. And they're like, oh. And then they collaborate with you and you have these great outcomes. It's like, well, yeah, we all bring a little bit of something to the stew. Yeah. It's not just one size fits all. And I'm excited today because I want to bring light to chiropractic care in pregnancy, why we refer, because I refer people to you all the time, whether they're trying to get pregnant or they are pregnant or they're struggling with a certain symptom or just in labor, we're heading for a C-section and the client is like, one last thing, what can we do? Let me dial a friend. Yeah. And I have called you at 1 a.m., literally at 1 a.m., and you have shown up and helped in a hospital setting, unplanned. What was it? 2 weeks ago, you went to my client's house, or my client came to your office at like 11:30 p.m.
Yeah, very late at night.
Very late at night, I called you and I said, "Hey, like we're heading this way. I really think she has this, tightness in this area. Do you think you could help?" It was Saturday night. You said, "Yeah, send her over to my office." And I think they were there till late. You all had a really good time.
Yeah, we had a party.
You had a party. Yes. They loved you, and they really enjoyed the visit in therapeutically and just who you are psychosocially. And she went into labor a couple days later and had this glorious, glorious, glorious delivery.
Sweet couple. And also, it's really, when your clients come in, it's almost like you're in the room with us. Also, your energy is all over them, and we're collaborating even when you're not there.
Thank you. I appreciate that. That's really sweet. Tell me a little bit about these blockages that you open, specifically related to pregnancy and someone who's looking for a less intervened vaginal delivery.
Okay. I do look at chiropractors like we're WD-40 for the bones. So wherever two bones come together, they form a joint, and there's supposed to be movement between the bones around the joint. But sometimes the movement gets restricted or completely locked up. Any two bones in the body that come together that are locked up create a problem. It could be a problem that you feel. It could be loss of range of motion. I can't move as well. It could be pain. But sometimes it just creates a rigid environment where there's supposed to be fluidity. There's supposed to be movement. And chiropractors love, and there's a lot of different ways to do it. So you go to 10 different chiropractors, you might have 10 different experiences, but we love to search through your body for these restricted joints and release it and somehow restore motion between the bones around the joint. And then the improved function is the primary goal. But then the sub goals are, now you feel better. And now if you need your body to act in certain ways, you have the fluid movement that was programmed there. With our practice, we also do soft tissue. I went to massage therapy school separate from chiropractic school. I smushed them together to make the peanut butter and chocolate of holistic healthcare. That's my goal. Because the muscles and bones are deeply intertwined. And so with massage, we can work on soft tissues, muscles, ligaments, tendons, fascia. Any soft tissue that can shorten can become too short, too stiff, too tight and rigid. And it's the same thing. You might feel that as a symptomatic loss of range of motion, pain, or it could pull too hard on the things it's attached to and create issues, or compress the things like vessels and disc material, nerve material that run in between. And so we use it diagnostically to find those tight soft tissues, and therapeutically to release them and restore normal length and normal tone, release the grip and the compression, but also it gives you that fluidity. So when you think about childbirth, number one, the pelvis is not just a big bone. It's a bunch of smaller bones connected by ligaments and cartilage. And when you realize that, you realize it's not just a static structure. It should have a lot of dynamic mobility, and even just positioning before labor starts, when the baby's looking to get into a good position. At 28 weeks on a first pregnancy, roughly half the babies are breech or not head down, and then just 4 weeks later at 32 weeks, it's only 10%. So the big migration happens when they run out of space. They can't keep moving wherever they want to. They have to pick a position, and generally head down is the most comfortable fit for a typically shaped baby and a typically shaped uterus. But if there's a lot of stiffness, tightness, and rigidity in that area, it very well could be the messages go up under the rib cage where there's more space, not down into the pelvis where it's really restricted. And so one of the things we do is open up that space. We do a lot of breech babies and otherwise not well rotated babies.
Right.
We're not moving the babies. I'm not doing anything to the baby. I'm opening up the incentive, the invitation. Let's make this an open, relaxed space. The body's trying to do that hormonally with relaxin and other pregnancy hormones. But if everything's just locked up, then we can get in there and release those muscles, release those bones, and make a more inviting environment for the baby to want to go head down. But also then once the baby's trying to move, if I can unlock those structures and they can expand and contract and accommodate or facilitate the movement, that'll give us a much better going into labor position than if they can't. Now it's the same thing. Once labor starts, the uterus is kind of squeezing down and trying to maneuver the baby through the pelvis. If everything's rigid, it's hard to maneuver. Babies kind of get stuck posterior and the skull's against the spine, and it's not great for the mom. It's not great for the baby. It's not great for the midwife.
It's those are the long ones, right? And viewers and listeners, we throw a lot of terms around like anterior and posterior and asynclitic and sunny side up, and we want the baby to the left and not to the right, and what do all of those mean? In a nutshell, the uterus is not completely parachute shaped evenly on both sides. It has a slightly larger angle or a slant on the left side. So we actually prefer babies to be on the left side and head down as they get towards delivery, just because the slope in the uterus causes the head to flex, and the diameter of a flexed head is less than the diameter of a deflexed head. And a lot of times when you have these long labors spanning hours and days, and clients are exhausted and moving towards interventions, whether therapeutic rest and Pitocin or a C-section or whatever it is that needs to be thrown out, it's because at some point during this time, the baby didn't necessarily come onto the left side, but came onto the left side and didn't make a complete rotation. So when we talk about this OP baby, which is an occiput posterior, which means the back of the head is facing the back of the mom, in front of the back of the head is facing the front of the mom, which makes it a lot easier to come down under the pubic bone. So essentially what Dr. Berlin does is go in and open the environment so the baby says, "Oh, thanks for that room. I was just waiting for that because it will really help me to come down." So I know you have a lot of success with the Webster technique. Can you tell us a little bit about what that is?
Yeah, Dr. Webster was a chiropractor in the 1970s, and he wondered, why do some people have breech babies and some people don't? My understanding is his daughters had breech babies that are very athletic, and so he looked for things that might restrict the ability of the baby to move into what should be the ideal position, and he landed on some of the musculoskeletal structures as well. So he looks very much at the sacrum, the foundation of the spine, and the round ligaments, which the round ligaments anchor the baby into the pubic bone. And so he has an analysis where you're looking for restriction on either side of the sacrum and tightness in the round ligaments. And you kind of stretch or massage out the tightness if the round ligaments are taut. They run right over here, so they when they tighten up, they can maybe create intrauterine constraint where it's a little bit harder for the baby to move around. And they do respond really well to just stretching and massaging them out. They loosen up really well. So some people have round ligament pain during the
many
pregnancy, and it can be so sharp and searing that they think something's horribly wrong and go to the emergency room like, oh, it's just your ligament spasming, because they have muscle fibers running through them. So there's that. And then the sacrum, if it's stuck on one side, we adjust that side or the other side. And if it's moving on both sides, we leave it alone. Or if it's stuck on both sides, we adjust it. So that was his approach to improving function. And he's addressing the bones and the ligaments. But as a massage therapist, I took that idea and moved one step further into all the musculature that's around the pelvis as well. There's a lot, and not just the ones right in the area of the pelvis, but a lot of the muscles of the body that going up into the torso and down into the legs anchor and attach to the pelvic bones. And so we really kind of loosen up all of that and try to make a much more flexible and accommodating environment for the baby. The premise is that babies want to go head down at the end of pregnancy, and that they also want to be in an ideal position for birth. And when the body's able to accommodate that, then they generally go.
So what is your success rate?
Oh, it's so hard. So my first week, it was 100%. I think I did probably 3 babies, and not my first week, but, over time I did probably 3. I worked with 3 clients who were breech who came in hoping for a better position, and they all ended up head down. So 100%.
3 out of 3.
And then on the 4th one, that baby didn't turn, and all of a sudden I was down to 75%.
Oof.
So the success rate is interesting. I could give you a number, but it really doesn't mean that much to most people. What really means more to them is what is their personal chance of success. And there I look at a lot of factors, right? Because, I'm just working on functional things, but there are structural things. If you have a very high up placenta and a very short umbilical cord, baby's going to stay up there almost no matter what we do. So your chance of success is very low. If the uterus has a variant shape, like a heart-shaped uterus with a septum coming down and the head's kind of stuck in one lobe of that heart shape and the legs are in the other lobe, and it's a big septum, it's going to be very hard for the baby to move past that.
A septum is a wall in between 2 sides of the uterus. It's a fancy word for wall.
So, if it's a baby that's been, for example, kind of wedged into a breech position since week 20 and hasn't budged, and now it's week 37, there is going to be not a factor that works in your favor. If the amniotic fluid is on the lower side, not a factor in your favor. But if it's on the higher side, it could be better. Anterior placenta, when the placenta is on the front wall of the uterus, more likely to get in the way than when it's on the back wall of the uterus. And if it's also not your first pregnancy. So if you've already had a head down baby, born vaginally especially, then your odds are smaller that you're going to end up with a breech baby at the end of this pregnancy. Right. So I really look at a lot of factors. Some of them are structural, some of them are functional, and try to give somebody a better sense of what are their personal odds of success. So I would say overall for me, about 66%, about 2/3 of the babies that come in that we see end up head down one way or another. But that includes people who come in at 41 weeks after a failed external cephalic version. We've had success there, but I would tell anybody who came in at that point, very, very tiny chance. I'm happy to give it a try because all I'm doing is improving the function of your muscles and bones, but I don't want to get your hopes up in that scenario. So I think it's more important to look for somebody like, what are your particular factors and what are the chances that your baby will turn? Because the things that they do, everything is sort of like a risk-benefit analysis, a pro-con analysis. So how much time, how much money do I want to invest in chiropractic? And if I don't like it, how much discomfort do I want to invest in chiropractic or acupuncture or moxibustion or these inversions that I'm doing and other things that people do to try to get the baby to flip, or the external cephalic version where they try to forcefully manipulate the baby into an ideal pre-birth position. And so in order to do an honest risk-benefit analysis, you sort of have to know what your odds are, what factors are working in your favor, and what's working against you.
Including anatomy, because we just had a guest on, Josh and I, where she had was it 5 breech deliveries, Josh? I think she had 5 breech vaginal births.
Oh, wow.
And 1 C-section. And she's pregnant, God willing, and planning another vaginal birth.
Oh, wow.
And so what's going on there? Is it the shape of her uterus?
Almost definitely, I would think.
Right? But her body is very capable of having, thank God, very easy breech vaginal deliveries.
Mm-hmm.
And a provider who'll do it, which most providers now are not doing it, which a lot of what your movie is about, your documentary is about. Tell me a little bit about that, because I love that documentary.
Oh, thank you. Heads up. So
very well made.
Thank you very much. It was my first adventure in filmmaking, and it really just came out of seeing so many people. You know, over time, I've built up a lot of reputation for the work that I do with positioning. So rarely is there less than one person a day coming for help with positioning, and so when you see such a volume of people coming through, you see some cases. It started like this. I had a patient who had 2 vaginal births with roughly 7-pound babies, smooth deliveries, uncomplicated. She would call them fairly simple and straightforward. And the third one, also about 7 pounds, was in a frank breech position. So butt down, legs up by the head like it's doing a pike dive. The safest, easiest type of breech to deliver. And given that she had 2 vaginal births already, almost definitely, no matter what the study was, almost definitely for her, like if you did 100 people like that in a study, they're going to have better outcomes for mother and baby with the breech birth than with the cesarean birth.
Yep.
However, nobody in her practice was skilled or comfortable attending a breech birth. And so they basically, told her, you don't have an option. They scheduled a C-section. She had one, and it wasn't a particularly great cesarean. Sometimes people love their cesarean birth. She did not. And when she found out afterwards that there were doctors in town who would have attended breech birth, but they hadn't told her, it was a terrible feeling for her. And so I started to put together media because of stories like that. And when I started to think about breech and do research into breech and understanding when we stopped doing breech and why we stopped doing breech, it was really eye-opening for me. I was like, I can't believe it. And she's not the only one. She's almost like an extreme example of the best candidate.
Best case scenario, because that breech study was flawed.
The breech study was flawed. So 2001, Mary Hanna and colleagues in Canada at McGill University. I think it's a fair question. A cesarean birth became and continues to become safer and safer. The question is, who's going to benefit? Who's going to be better off having a cesarean birth versus a vaginal birth? You have a complete placenta previa, and there's no way for the baby to come out without smashing through the placenta. I think most people would agree then you're better off having a cesarean birth. And again, it's become safer and simpler. And so the question that they asked was, what about breech? We know certain things can go wrong during a breech delivery, complications that can happen during a breech delivery that don't happen with head down babies and that don't happen with C-section. So maybe the hypothesis was babies who are breech are better off being born by cesarean, a planned cesarean, versus any kind of vaginal birth. And so, I think they took roughly 2,000 women who were breech and agreed to be a part of the study.
Yeah.
And they told half of them, we're going to deliver you vaginally and half by cesarean. Of course, not all of them ended up that way because some of the ones aiming for a vaginal birth ended up in cesarean anyway. And actually some of the ones that were scheduled for C-section popped out early. So their conclusion was that breech babies have a small but statistically significant better outcome when they're born by planned cesarean versus vaginal birth. And it was like published, and overnight the United States and Canada just like, okay, we're not doing breech birth anymore.
It's like they were waiting for it. It was almost like when they didn't let doulas in the room during COVID. It was like they were waiting for a pandemic to be like, nobody's in the room, including the doula.
Right. Or the Arrive trial, which came out more recently, indicating maybe induction at 39 weeks could have a benefit. Boom! Now we're going to induce everybody at 39 weeks. It's based on a single study, a limited study, without even really giving the study a chance to marinate or establish itself. Then 2 years later, they do a study on the 2-year-olds from the original study, and they find no long-term difference in health. Well, now we're scratching our head. What does that mean?
For the breech.
For the original breech trial.
Yep.
Hannon et al. Did the follow-up, the same group, and no long-term difference in health. And then it's 2 years after that a researcher named Glazerman had gone through the whole original study and pointed all these different concerns with the study, some of them flaws with the study, and for example, babies who have congenital issues that have nothing to do with mode of delivery should have been removed from the study.
Exactly.
And there's more of them in the vaginal category than the cesarean category. That skews the results.
Absolutely. And people showing up to hospitals that are not specialized in delivering breech babies or caring for babies who are compromised from a delivery.
Right. No NICU. It was 27 countries and a whole bunch of different...
No prenatal care.
Some of them had... not even some of them had no way to determine the type of breech. So to do selection,
exactly.
Is this a better candidate for breech birth or not a good candidate? And once you compensate for all those factors, now we don't know anymore if that small but statistically significant benefit is even there. And so to take away that choice for so many millions of people seems like a major flaw. And so his recommendation was that the term breech trial conclusion be withdrawn. And it was actually 2 years after that, because the American College of Obstetricians and Gynecologists, they had come out in 2001 saying our recommendation is all breech babies be born by planned cesarean. And then they just stopped teaching breech birth, and they stopped practicing breech birth. 2 generations
now of physicians don't know how to do it.
They don't know how. I have several that wish, they had the training, but you can't even resume the training because there's not enough volume of people doing it to properly train somebody to have enough confidence and experience to be able to go do it. So it's really just the old timers and a handful of very intellectually curious young doctors who are sort of trying to carry the torch, but it's really a dying art. And so in 2006, I believe, ACOG changed their guidelines. They revised their guidelines saying, you know what, actually, with all this new data, maybe vaginal breech delivery is a good option for certain candidates. If you can find a facility and providers who are still skilled and confident in doing it.
And preferably a multip.
Right, they give
who
more.
Hasn't had a VBAC. I mean, had all these parameters, which are commonsensical, really, because many of the complications that we see in obstetrics, if they happen once, they can happen again. And so one would think that a pelvis that has already shown that a baby can come through it successfully is going to be able to do that for a breech baby or a head down baby.
Right. And
theoretically.
So not all breeches are created equal.
Correct.
And if you do selection, if you do say, is this a good candidate, both in terms of the baby and the mother, then you can sort of weed off who's a very good candidate, who's a not very good candidate, and everybody in between. But that is still part of their risk-benefit analysis that they will do. If you present it to them, this is why you're not a great candidate for this. I think any person who's giving thought to their decisions will be like, I might be better off having the cesarean birth, but it's a choice that they come to with you. It's a collaborative choice. And that just, even if they end up having the cesarean that they didn't want, it's just a whole different experience because they were the decision maker. They were in the driver's seat.
They were autonomous, right?
Yeah.
And I think a lot of trauma happens when we feel like, wait, no one told me that. That's I had that feeling after I had my first, because my listeners have heard this over and over again. The nurse who was in the room when my daughter was being born, there was no doctor in the room, and she literally wouldn't let me push. So she put her hand on top of the baby's head. I was completely unmedicated, 19 years old, healthy, ready to push out this baby. And she was like, you will not push. And she held the baby's head in. So my trauma afterwards was, why did nobody tell me that actually I could have told her, move your hand away and just catch this baby?
Or you could have caught the baby.
Or I could have caught the baby myself, or my partner could have, or she could have gotten the charge nurse or the resident or whoever was close by to catch the baby. Because babies that are coming out that fast to low risk healthy people are typically going to do okay. Typically going to do okay.
You don't have to wait for the surgeon to get
Right,
there.
exactly. So for me, the reason why I'm here as a licensed midwife and educator and now have this podcast is so people can realize their choices to avoid some of that. Like, really? That was really horrible what happened to me. And no one ever said that, hey, guess what? This is an option for you. Would have been life-changing. Yeah. Would have actually maybe not made me a midwife today, which would have been sad. But it certainly would have gotten rid of some of that trauma of not knowing and the dissatisfaction. And the doula who I hired, Cheryl Baker, who we both know from our early doula careers, she's retired now, enjoying her grandbabies. But for my second birth, I hired her and we told the nurse, like, hey, if we need to push, just catch the baby or call a doctor. Just easy does it. Don't push the baby back in. She's like, I will not do that. And she ended up catching the baby, which was a pivotal. Again, the doctor wasn't in the room.
Yeah.
But it was a completely different scenario because I felt autonomous in that decision. So on paper, it looked very similar, but the experience was completely different. So I can imagine this woman who had 2 normal vaginal deliveries and had a breech baby might have been a really good candidate. No one told her. It's a really yucky feeling.
It's devastating for her. And you see it in the film, actually. I started feeling like I need to tell this story different than a podcast. We already had a podcast and we had a magazine at the time. It was like all under informed pregnancy. But this one felt like I wish that some of the doctors could feel the emotions or experience the feelings that these moms were having. And I couldn't get it. I couldn't get it in a podcast. I really wanted to document the stories and I had no idea what I was doing. I was looking at like New York Film School. Hi, is there anybody there who can like come film an interview and this and that? And we got one kind of celebrity to do an interview and then she was so gracious with her time, and it was hard to find a time that worked for everyone. And we sat down and had this guy from film school. He seemed really pro, and he set up the framing really nice and everything like that. And we had a great interview. Well, he called me and he's like, I forgot to turn on the audio. So I only have pictures of you guys. And then I had
some really good pictures, though.
Yeah, really great interview video with no sound. And so I had to call her back. And I'm like, you're not going to believe this.
Oh, my gosh.
I love talking to you so much. And she was really gracious and did it again. But wow, that's how I made it. Like, I had no budget for it. I had no experience in telling a story that way. I didn't realize there were different film speeds and things like that. So when I had a patient who was really great. Her name's Mel Kennedy, who had a breech situation of her own, and I was able to work with her. And when she found out about the project I was working on, she's a director and a film editor, and she's like, I'm going to help you with this. And we sat down, and when I showed her the little mishmash of recordings I had put together, she's like, okay, harder than I thought, but let's get it done. And she brought it to life. And then I had a patient, and her husband is a composer for film, and I helped them with their breech baby. And then it's such a great experience that he's like, because he's a real professional composer, and I'm like, I can't afford you. And this was years ago, and I was just
he did the score,
yeah, he did the score. And when I heard it the first time with the music, he scored it specifically for the film.
Wow.
I had seen the thing probably 100 times. I saw it the first time with music, and I was crying. It tells the story in a completely different way.
It was made for you.
It was made for me. Just the music tells the story and brings the feelings like even deeper, like kind of like salt on a good dish. And that just brings out the flavor. And our second film we made about VBAC, trial of labor. At that point, I had a much better sense of what I was doing.
You were a pro now. You were
I was a multip. An incredible filmmaker who joined me on that project, and it just came out so profesh. They're both, I'm really proud of both of them, and they both have the impact that I was hoping they would have. Still, years later, people reach out over social media about the films, and
it's life-changing.
Just let me know that they've only found out they had a choice, through these films.
Yeah.
And so mission accomplished.
Absolutely. For every one person you educate, it's a ripple effect, right? So you're helping people for generations to come. So you and I met because we were in the same community, and I was a doula and you were a pregnancy specialist chiropractor. People were talking about the work that you were doing, and you and I sometimes collaborated with clients. What I didn't know is that you and your wife, Alyssa, had quite a journey of your own conceiving and having babies. I always thought that you became a chiropractor and you decided that your niche was going to be pregnancy. And it actually turns out that it was a whole journey that made you get here. Can you tell me a little bit about it?
Sure. I watch my son play video games, and sometimes in his video game, they don't come with instructions. I'm like, how did they even figure out how to play these games? And so many intricacies. But I do notice that once in a while he's going and he gets to a path and he's like, which way do I go? And a big arrow pops up and it's like, go this way, go this way. And I feel like my life has been like that in a way that I'm really grateful for. Cause I just love what I do. And I never would have, like, when you asked me when I was a little kid, what do you want to do when you grow up? I'm like, perinatal chiropractor. That just never was a thing.
Right.
I wanted to be a medical doctor since I was 7 years old. I was studying to be a medical doctor, and my father unfortunately passed away partially from a medical mix-up. And so I switched gears and I wanted to do healthcare, but not drugs and surgery. Thanks. And so after college, I took a year to like make pizza and also study what other healthcare modalities I could get behind. And I really fell in love with the combination of chiropractic and massage. Chiropractic being so powerful in the way it clears the nervous system and the body's doctor and its ability to diagnose and heal itself, and to assist in the body's ability to do that.
And the immune stuff too, which I had no idea about. Helps with immunity.
Yeah, there's great studies on chiropractic and immunity. And
it's crazy.
So I went to school for massage and chiropractic separately, and pushed them together. My wife probably has been a therapist since she's 3 years old. She's really easy to talk to and makes people feel better.
Atoosa Berlin, look her up.
Yeah. So she was in grad school at the same time in Atlanta, Georgia. And towards the end, we're like, let's, good time. Let's have a kid. And we followed the instructions and no baby came out. And we ended up going through a really intense roller coaster of fertility treatments, medical fertility treatments. And we exhausted what they had to offer. It was unexplained infertility. They didn't really know why it wasn't working. Mm-hmm. We did IUI, we did IVF, we did more IVF with different drugs and different protocols.
And you were in your 20s, right?
In our 20s. By the time we were done, we were 25 and 27, and they gave up. They're like, we don't think you'll ever have kids together this way. Go think about like adopting or egg donor or something like that.
Surrogacy or something.
Yeah, I mean, we couldn't even like get an embryo.
And thousands of dollars.
I mean, so much money, none of it was covered by insurance. So it was just like, and to that point, by the time they told us that, we were so broken in so many ways that we didn't even feel ready to be parents anymore. And so we just said, let's take a break and fix ourselves, heal ourselves. We were physically run down. We were spiritually run down, mad at God. Why would you do this to us? We were relationshiply run down. It's a very trying journey.
Takes a toll.
We were financially broke as heck. And we were living at that point in Lincoln, Nebraska for my wife's internship is why we went there. And also to see what it would be like if there were two Jews in Nebraska at the same time, because that's what it felt like.
You got out though.
We got out. Yeah. It was really great. I loved it. It was an interesting experience for a New Yorker to be at the pace of life of Lincoln, Nebraska. And they have beautiful bike trails, just hundreds of miles of beautiful bike trails. And we took up biking. We bought these 2 used bikes on eBay, and we just started biking and bonding and eating better. And we both had jobs and were earning money and not spending it all on fertility. And it's when we kind of took up yoga, meditation, acupuncture. We really were getting healthy. And Then we moved to Los Angeles for her fellowship. And once we kind of got here, we're like, okay, we can revisit, like, how do we want to become parents? What are the pathways that maybe, like they said, adoption or egg donation? And we found out we were pregnant. It was like the biggest surprise ever. And we opened a practice together, mind and body practice for general health and wellness. But we always from day one had an eye on how can we help people boost their natural fertility. And in the first year of focusing on that, we had a couple of babies come through the practice. And then every year after that, just snowballed. Babies, babies, babies. And so...
Babies to be treated.
Well, pregnancies, and then because of the pregnancies, and our clients would be like, hey, we want to keep coming to see you during the pregnancy. I'm like, oh, I don't really know much about pregnancy. But they were insistent.
Said he. Yeah.
So I did a lot of homework and research, and I talked to the pregnancy-focused chiropractors that I knew that I could find.
Both of them in the world.
At the time, there weren't that many. And so I was able to learn a lot. I definitely felt confident that I can do chiropractic on you without harming you and without harming your baby.
Yeah.
And over time, you start to realize there's so much more that you could do with chiropractic for the pregnancy, not just to avoid harming the pregnancy. And that's how it evolved. And once you're doing that pregnancy, eventually someone's like, can you come with me to my birth and help me with my back pain while I'm in labor? Or like you said, I got a call from a midwife one time that I think she was 9 centimeters for 9 hours, and they were at the end of their rope with this home birth, and she really didn't want to go to the hospital. I'm like, let me try this chiropractor. I was in Petco trying not to buy this guinea pig for my kids on a Sunday when she called. And she's like, can you help with the posterior baby? I'm like, I think I would just do the same thing I normally do, loosen things up, try to make a functional environment. And she's like, I have a client for you. I'm like, I'm available on Tuesday. And she's like, no, right now you need to come to this birth, 9 centimeters, 9 hours. I'm like, okay, we can't buy the guinea pig, kids. Get in the car.
Yeah,
we go home.
No guinea pig today.
And I walk into this birth, and it's like in progress. It's a person I've never met before. It's the first time going to a birth that's not my own kid.
Wow.
Nobody told me they were filming for a documentary, and there's like 6 cameras around the room, and I'm trying to do informed consent, and she's high as a kite on her own drugs that she made, the
oxytocin high.
And it's just, I've never seen anything like it. I'm trying to be like, so I'd like to do like a combination of massage and chiropractic with you, and I'll be massaging over here, and would all that be okay with you? And she looks at me in the eyeballs, and she's like, I love you, Mr. Berlin. I'm like, okay, and so I start working on her.
She was in labor land for sure.
Loosen her up, and it is working. She's loving it. I mean, all I can think about is like, how's my bald spot looking, camera 2? And and things open up, and eventually, like, probably was there maybe for an hour and a half.
All on film.
And it just like clunked into place, all on film. And she said, she cussed, and she said, I think you just saved the birth. And like 40 minutes later, the baby was out.
Born. Wow.
And so after that, midwives were like, I have this.
He's got some magic
mama
skills.
whose baby, we're stalled. It's posterior back labor. Can you come over? And that's just snowballed into doula work. And then with all these babies, I started to do newborn care. And, I guess eventually I'll be doing geriatric care, and then I'll retire.
So you see newborns?
Yeah, I saw newborns for a long time. I got really lucky a few years ago. A chiropractor married somebody in Los Angeles. She moved here from a pediatric clinic, and she loved doing babies. And I was just getting so swamped in my schedule. And it's sort of like adults and babies are so different that the flow of my day was really weird, going back and forth, back and forth.
Yeah.
And so when she came in, she took over all the babies. And
is this Dr. Dirks?
Before her, Dr. Suzanne Frank. And now we have other chiropractors that are very baby focused, and I don't really do them anymore. If I'm at a birth, I'll check the baby, soon after they come out.
It's a plug for Dr. Dirks, though.
Yes,
my daughter swears by her. She calls her like the magic baby chiropractor.
She is incredible. We have
Loves her.
Another one like her, Dr. Katie Fowler in the practice, Dr. Jenny Crenton. We have a whole team now, and because of that, I don't do babies very much anymore. Someone once said, like, how old is your youngest patient? And I was like, 90 seconds, because I was at a home birth and baby came out a little not eager to take that first breath, and they were doing all sorts of things, and It's just like, can I check the spine? You know, and I just did a very tiny adjustment on the baby. Baby's fine. Baby ended up doing well, but that was like 90 seconds after birth. So I guess my youngest patient was 90 seconds.
So what are some reasons that people would see a chiropractor for a baby?
There's general, like
Yep.
sometimes
Just general
people just come
holistic
in.
health.
We want to make sure everything is lined up
Yeah.
from day one.
Yeah.
As it starts to grow and solidify, better to not have restrictions in there. People come in with babies for latch issues. If they're not able to latch well, it could be something with the baby, with their mouth, with their bones, and their musculature. We get a lot of babies that are kind of taco neck to one side. We get babies that are very central nervous system irritability, so excessive fussiness. They don't sleep well. They sometimes shows up as digestive dysfunctions, I guess, and irritability. Those are all things that oftentimes respond really well to chiropractic, or we also do craniosacral therapy.
Talk to me a little bit about the difference between craniosacral and chiropractic.
Craniosacral is part structural and part energetic.
Oh, okay.
It's one of the newer energy modalities. It's probably just over 100 years old.
Okay.
And it works on this rhythm that flows through the body called the craniosacral rhythm. And it's independent of the heartbeat and the blood flow. And it's independent of the lungs and the airflow. And it's a rhythm that happens like 4 to 12 times a minute. And it's almost like the gills of a fish kind of rhythm. It's not like a pulse like the heart.
Between the skull and the sacrum?
So it originates in the dura mater, the specialized connective tissue that shrink wraps the brain and spinal cord. And underneath that is this cerebrospinal fluid, the specialized fluid that bathes the nerve tissue that make up the brain and spinal cord and bring it nutrition and take out waste product. And so the flow of the cerebrospinal fluid is related to the craniosacral rhythm. And
Got it.
you can feel it not just from the cranium to the sacrum, which is where that fluid flows and where the dura mater is. You can feel it all throughout the body, all the way down. You listen with your hands in different parts of the body for that rhythm.
Wow.
And it takes a long time to be able to kind of get a feel for it. And when you feel it, and it's not what it's supposed to be, it's either not even from right or left, or it's out of sync, the frequency or the strength of it. The remedy is you just hold a very gentle pressure, so like 5 grams of pressure, sometimes for a minute, sometimes for 30 minutes.
You hold space for it.
You hold space for it, and it starts to balance out, equalize. And the central nervous system, you could almost feel it take a deep breath and relax.
Regulates.
And it regulates. And so when people are in fight or flight, and then you do craniosacral with them, the whole central nervous system moves away from fight or flight. I'm no longer being chased by a tiger. And it's a different existence in life.
Wow.
When you're not in the mode where your nervous system feels like you're in danger all the time.
Right.
So it's part structural and it's part energetic. It's extremely gentle.
It's a finger, really. It's not like when you think about baby chiropractic, you're not talking about taking your hands and adjusting a baby. Oftentimes I've seen it done with a finger.
Yeah. So craniosacral could be, we do it with adults and babies, and it's very gentle. Yeah. People wonder, like sometimes I'll have a patient, she wants to bring her baby, but her partner is very nervous about it.
Yeah.
Like,
Yeah.
We don't do that to babies, like newborns. It's what you're saying is a sustained contact. There's not a whole bunch of life trauma locking that vertebra into place. It's just not where it's supposed to be. And if you hold the right line of correction on it for, again, 60 to 90 seconds, it usually just slides back into place like melting butter, you know. It's very gentle and very powerful.
That's amazing. So when we think about the early trauma that could cause a baby to be colicky or not breastfeed or not latch, it could be anything from the birth having something that wasn't making it super smooth to the moment at which the baby is born and possibly wasn't put skin to skin or reunited with the birth person, in which the baby had trauma because coming down a vaginal canal or coming out of an abdomen by a surgeon is traumatic to some extent to the baby, which I actually believe, in my opinion as a midwife, that some level of shock is necessary for us to enter this world. We actually need that difference of like, whoa, what just happened here? For our systems to sort of come in, maybe for our soul to fully integrate. I don't know, but I believe we need a little something, because even with a water birth, which is the baby being born underneath the water and it's super mellow and super chill, ultimately you have to take the baby out of the water.
Yes.
Right? It's not like the baby stays in the water for the next 30 years, right? It's the baby comes out. And when that baby comes out, there's a level of trauma too. It's cold. It's different. What just happened here? So I believe that.
You're my dad? Okay. That's what I picture my kids thinking.
Josh just jumped up. He's like, what was that? There's an inherent level of just, I think, shock that has to bring us in fully. Right. And that causes a baby to take that breath, and all the different things that happen between the heart and the liver and all the vessels that close and open, the magic that is going from a water mammal to a land mammal, which is what we do. But then the trauma doesn't calm down if the baby is not given to the birthing person so that the dyad can transition together. Because what we know is babies are born. The inside of the body is typically much warmer than wherever the baby is going to come out into. Most people don't keep the room at 97.6 degrees, right? It's too hot. So they're cold. Their blood sugar is high because they're in a bit of a stress state. Their heartbeat needs to regulate. And the birthing person, typically is planning on holding the baby and keeping the baby and raising the baby in most situations, is going, look, where's my baby? Give me my baby. Give me my baby. And when you take babies away from moms to resuscitate them or measure them or bathe them or all the things that we do, whether we need to do them or not, there's a separation that happens that keeps the central nervous system of both of them in an agitated state. And I believe that then at some point when you give the baby back, or the baby goes to where they're supposed to and begins to either bottle feed or breastfeed, they're still holding a little bit of that tension in their body. It takes them longer to regulate. And I think depending on how sensitive the baby's constitution is, that maybe never fully goes away. That vibration stays, in my opinion.
The contrast between what I witness as a doula at home and at the hospital.
Oh yeah, he's a certified doula also. Love that.
The contrast sometimes is so stark. There's a lot of thoughts swirling through my head right now. For one thing, a baby could just be in the womb in a tough position. And sometimes come out and need some chiropractic care because of that position they were in. But also, early on, and I don't come from a holistic background. I was like working in emergency rooms and ambulances as a medic, and I was on my way to medical school. My whole vision was drugs and surgery until the arrow,
moment, the God arrow,
until the big arrow came up. Yeah, and so
it was ways.
I wasn't in that holistic mind space even when I started doing pregnancy and birth and. People would come out with their babies and I would feel these necks that felt traumatized. And I was like, how does this brand new neck have this kind of tension, ropiness in the muscles, like something's been overextended or a restriction that's a response to something that was trauma. And I would say, did they drop the baby? Like what happened here? And like, no, the birth was great. And I was like, eventually wondering, because one of the moms, she's like, no, the birth was great. I have it on film. I'll show you. Everything was very smooth and peaceful. It took like a minute after the pushing. The baby just came right out. So it's like, yeah, I'd love to see that. And what you see is the baby comes out, head, and then the doctor takes the head as if there's an urgency to get the rest of the baby out, which in that case didn't seem to be. Not a medical doctor, just didn't seem to be.
I just saw this.
And they used the head to leverage and manipulate the baby to try to pull that shoulder out, shoulder out. I'm like, that's where that's it. Like the doctors didn't mean anything bad by it. They're just trying to get the baby out.
It's just training.
And when you see the contrast between that, and sometimes I'll be at a home birth and she'll push and then the head will come out. It could be like 3 or 4 more contractions. Many minutes go by, and nobody is panicky or alarmed.
So long as the color is okay.
Right. Again, I'm not a medical doctor and I'm not a midwife.
Yeah.
I'm just saying, I've witnessed this where they're on top of it.
It doesn't have to be handled.
Everything's okay.
Yeah.
But they don't even touch the baby. They just wait, until then all of a sudden a shoulder emerges and another shoulder and the baby comes out. And like the contrast between those two things and the contrast between the babies, how they feel, their little spine feels after A versus B is huge.
It's different. It's definitely different.
And so the question, why would a baby ever need to see a chiropractor, is like, well, sometimes there is trauma, and again, it's not intentional. They don't mean to be doing anything bad, but when you see both, I think you're like, I want my baby to have that one.
Yeah, not have
all
that.
things being equal, if there's no emergency.
From hello, yeah, literally from hello. How do you think you got pregnant so easily with no intervention?
I'm a spiritual person, so I believe that when the time was right, God said, now is the time. And our struggles, like your struggles, really shaped your whole life professionally
and spiritually.
Our struggles definitely made us stronger in a lot of different ways that I don't know that we ever would have achieved without the struggle. On a scientific level, I really think it had a tremendous amount to do with that autonomic nervous system, the part of the nervous system that responds to stimuli around you and within you automatically, not the part that's voluntary, like I can choose to move my muscles, but I'm not thinking or choosing how many times to beat my heart and how deep. It just happens automatically.
Yeah.
That whole autonomic nervous system has a spectrum of operation that on one polar end is pure emergency and on one polar end is pure relaxation. It's the fight or flight versus the feed and breed, or the sympathetic versus the parasympathetic, and it's constantly, assessing where we are, and very predictable things will happen during the more emergency mode of operation. Your pupils are always dilating and constricting if there's more light or less light, but in an emergency, they'll dilate and let in the full view of the battlefield, even if there's a lot of light, so that you can see everything and react quickly. You become much more sensitive. So if you feel something that you can react to in a very big, strong way, your heart starts to beat a different way, your breath goes a different way, your body starts to shunt blood flow into your arms and legs so you can run faster or fight harder. You break down stored up energy at your liver, the glycogen, into glucose and bring it to the muscles so you could run faster or fight harder. Those are things that are in survival, and what you don't need in survival is your digestive system and your reproductive system. So when that emergency happens, you crap your pants and you don't get pregnant. And so the body deliberately shuts down when you're in that mode of operation, sabotages the ability to get pregnant or stay pregnant. And I think that's where we were when we were trying to get pregnant the first time. It's unexplained because there's so many different areas in the cycle of, the uterine cycle, the ovarian cycle, the sperm production cycle, the coming together cycle, the sustaining what's come together cycle.
There's so many things have to align.
Where the body could sabotage it if it wants to, that are not going to show up obviously on a test. And so it's unexplained infertility, but your body's saying no, no, no. And then all of a sudden you get to a place where you're not in fight or flight mode anymore. It's actually called feed and breed mode because your digestion and reproduction become much more efficient. And your body's like, okay, now is a great time. If you try, I'm going to do everything I can to help you. Or even our case where we didn't really try. And the body helped out. And so that's a big part of when we work on fertility. It's a big part of what we're trying to do. Look, if you have no uterus, like we can meditate with you all day and you're probably not going to get pregnant. But
different.
To the extent that the nervous system plays a role, it's very powerful in both its ability to stop a pregnancy and in its ability to initiate a pregnancy.
It's so interesting because there's so many stories of we tried for many years and as soon as we stopped trying, we got pregnant.
Boom.
We tried for many years. As soon as we started the adoption process, we went through 9 months of pregnancy and then adopted a 2-month-old, and we have 2 children under the age of 1. All the
Not
time.
infrequently,
There's something about letting go that I think relaxes. That surrender, I think, whether it's a purposeful, very spiritual surrender of, okay, we're going to try something else or we're not going to try, or even the angry surrender of like, I'm putting this down for now, which we see in people's journeys, because infertility is a whole other, is not talked about enough. It's more now. We're talking more about it than ever, but the psychosocial effects of it and the relationship part of it and the toll on the body, if you are trying different things, and then the financial toll, it's really not for the faint of heart. It is something.
Each one of those things is a factor that your body responds to. It's a stimulus that your body responds to in a way that feels like there's an emergency. That kind of stress and pressure.
Every single one.
And that's the whole thing. If you have this sustained, prolonged fight or flight response, even if it's not the full response, but it's elevated, you're going to see very specific symptoms like your blood flow. In order to bring more blood flow to your arms and legs, you have to take it away from someplace else.
Exactly.
You take it away from the non-emergency muscles, which is your posture, your head, your neck, your jaw.
Your genitals. It's not going to flow there if it's not time.
If you need that energy for emergency, it's not going to go. And so we always see people, with headaches and jaw discomfort and back pain because those muscles are getting a reduction in oxygen and blood flow. Nobody who's very stressed ever comes in. It's like, my arms and my legs are so stiff and achy and killing me.
Interesting.
It's always the posture muscles.
Yeah, the lower back,
and
the shoulders.
And they're always letting in too much light because their pupils are dilated. So they get migraines and their digestive system is really unreliable because it's constantly feeling like and so it'll purge and then it'll be, they'll get irritable bowel or they'll get other digestive like constipation. And they sometimes have a hard time getting pregnant or staying pregnant. Those symptoms all kind of are a pattern. You don't have to have all of them, but when you have like 2 or more, you see the pattern and you realize you're in fight or flight all the time. Some elevated mode of fight or flight. If we can find a way to bring you down into a more realistic mode of operation, then your whole life is going to get better.
Is different. Yeah, absolutely. I have 2 questions for you as we come to an end. Although with most of my guests, I could sit here for 8 hours and have such a good time, pull up sandwiches and just chat. What would you say to the male partner of someone who is struggling with infertility?
I generally find it's a generalization. Fertility is much harder on the female partner, much harder, and it's frustrating for both. And like for me, watching my wife, feel like her body's broken and, you're just told like you're going to probably get pregnant by accident. So you have to be so careful to not get pregnant. And then you're doing everything under the sun to try to get pregnant and it's not happening. And you have no control over it, especially once you start the medical process. You have no control and you're just like, it's the thing you want more than anything in the world at that moment. It's so much, I think, harder for the female partner than for the male partner. And it's a strain on the relationship. And so I think it's to the male partner, I would just say like, find a way for you to bring down your frustrations and your nervous system. I mean, communicate with your partner, but to just realize that it's on such a different level for them, especially when they see other people getting pregnant and their bodies are doing what they're supposed to, or someone says it was so easy for me. Or I remember for us, we would see celebrities announce that they're pregnant at 5 weeks or 6 weeks. I'm like, how do you know it's going to last? Like ours never lasts, and you start to realize, well, that's normally what happens. It just does work out. Find ways to be supportive, find ways to tap into communities where other people are struggling. And I think once you've experienced it or you are experiencing it, you're just in a uniquely different position to understand the person who's going through it. And, you don't have to go it alone. That's a big thing also. Like you just said, like people are now starting to talk about it more, but some of these topics like infertility and miscarriage that are never talked about, you're so alone and it's so much harder alone.
So many nuggets to take home. Such powerful work that you do, and the work that you do with your wife and the space that you have created. A literal safe space for families and for pregnant people and for your colleagues. You are beloved and loved in the community by my peers as well as by myself. And I would love to have you on again because we really could talk for hours. I'm looking forward to having Alyssa on too. Thank
She'll
you
be
for
a much
being my
better
guest
guest
today.
Thank you so much for having me and for your friendship and for your collaboration. My world is a better place with you in it.
Thank you. Ditto. Thank you. Thanks for listening to the Mamatoosa podcast on the Industry Plant Podcast Network. Mamatoosa is hosted by me, Atoosa Benji, and produced by Josh Stratton Carlson. Our theme music is composed by Mary Lalazarian. If you enjoyed the podcast, please consider leaving us a review and subscribing. See you next Tuesday.